here. It gives us immense pride and the privilege to welcome this distinguished gathering to the TechMed'26 academic research conclave organized by the Computational Intelligence and Medical Technology, a center of excellence under the Department of Computer Science and Engineering, Faculty of Engineering and Technology. In collaboration with the Faculty of Medical Science at Dr. M.G.R. Educational Research Institute, CIMT stands as a dynamic center dedicated to forecasting innovation, interdisciplinary research, and technological advancements in the field of computational intelligence, artificial intelligence, and medical technology. Through a continuous academic and research initiatives, it aims to bridge the gap between the healthcare and emerging technologies for the betterment of society. TechMed'26 serves as a unique platform that integrates technology and medical science through artificial intelligence, bring together researchers, academicians, industry experts, healthcare professionals, and young innovators to exchange knowledge and explore transformative ideas.
Today marks the beginning of meaningful discussions, collaborative research, and forward thinking innovation in the evolving domains of computational intelligence and medical technology. This conclave is not merely an academic gathering, but a convergence of ideas and expertise that aspires to shape the future of intelligent healthcare and technological advancement. With that, let us begin this auspicious occasion by seeking divine blessings. May I request everyone to kindly rise for the invocation of Tamil Varthu. Thank you. Please be seated.
Light symbolizes knowledge, wisdom, and enlightenment. To mark the ceremonial inauguration, I respectfully invite our honorable dignitaries to kindly come forward for the lighting of Kuttavilakku.
Thank you, respected dignitaries, for illuminating this occasion with your gracious presence.
A warm welcome sets a tone for every successful event. To formally welcome the gathering, I now invite Dr. S. Geeta, HOD and Dean, Department of Computer Science and Engineering, to deliver the welcome address. Ma'am, please.
Good morning, distinguished guests, dignitaries on the dais and off the dais, respected deans, HODs, faculty members, and dear students. On behalf of the Department of Computer Science and Engineering, it gives me immense pleasure to warmly welcome you all for the first edition of the Conclave, TechMed'26, organized under the Center of Excellence in our Department, Computational Intelligence and Medical Technology, in collaboration with Faculty of Medical Sciences, Dr. M.G.R. Education and Research Institute. This conclave brings together brilliant minds, innovative ideas, and inspiring perspectives from diverse field of engineering and medical technology. Today marks the beginning of a remarkable journey driven by curiosity, collaboration, innovation, and shared vision for technological progress and societal impact. With this, I welcome and thank our Honorable President, Engineer ACS Arun Kumar Sir, for his continuous support and always been a pillar of support and source of motivation for our department. I take pride in welcoming our Vice Chancellor, Dr. S. Geeta Lashmi Ma'am, who is very particular about every step should lead to a success that our department moves forward still further to achieve the best in all aspects. We welcome you, ma'am. I also extend a warm welcome to our additional registrar, Dr. V. Cyril Raj sir, whose mentorship and continuous guidance have helped us to execute all our endeavors. The chief guest of the day is Dr. Ramalinga Bethanayakan, Scientist of ICMR, NIRT Chennai. Our institution is grateful to you, sir, for having kindly accepted our invitation and sparing your valuable time with us today. Once again, we welcome you, sir, and privileged to have you with us today. It gives me immense pleasure to welcome Dr. S. Nirmala Devi, Senior Professor, Biomedical Engineering, Anna University, Chennai. She delivers a plenary talk today. We feel privileged to welcome you, ma'am, and delighted for your presence. I welcome the panel discussion panelists who will be joining with us in the afternoon. Dr. S. Balamurugan, Professor, Department of Respiratory Medicine, ACS Medical College and Hospital. Dr. S. Kripagaran, Senior Assistant Professor, Community Medicine, Government Medical College, Omandurar. Dr. N. Sudhakar, Scientist C, ICMR NIRT Chennai. Dr. E. Sivabalam, Professor and Head, Psychiatric C, Sri Lalitambike Medical College and Hospital. Dr. G. Rajesh, Associate Professor, Information Technology, MIT Campus, Anna University, Chennai. We welcome you all and thank you for your lending your expertise and insights. My heartfelt welcome to our advisor, Dr. Megata sir, who is always constantly supported in all our endeavors. And he is the person, along with the Cyril sir, for sowing the seed of this particular conclave, TechMed'26. So we, the department, mentioned the special thanks to Mehta sir and Cyril sir. My heartfelt welcome to our Joint Registrar, EPA, Dr. Ramesh sir, who has been a guidance person and constantly supported us in all our endeavors. A warm welcome to our mentor, Dean Engineering and Technology, Dr. N. Yatiraj sir. For always being a pillar of support, we welcome you, sir. I'm delighted to welcome the conclave conveners, Dr. Kumanan, Dr. Sendilvelan, Dr. Dr. Akila, for your effort and dedication have turned this vision into reality. And all the faculty members of our department and other department, especially from Faculty of Medical Sciences and technical staff members. Happy to welcome the students from our department and our group of institutions who have gathered here to witness the first edition of Conclave, TechMed'26. We are confident that the session, discussions and interactions throughout this conclave will inspire new ideas, foster meaningful collaborations, and pave the way for future innovations. Once again, I warmly welcome you all to the first edition of the conclave, a platform where ideas meet action, innovation inspires transformation, and collaboration leads to meaningful progress. Welcome you all. Thank you. I wish you the great success of the conclave TechMed'26. Thank you.
Thank you, ma'am, for your gracious and inspiring welcome. To provide an overview of TechMed'26 and its vision, I now invite Dr. T. Kumanan, Professor of CSE and member of CIMT, to kindly present about the conclave.
So good morning, everyone present here. Respected dignitaries, distinguished guests, faculty members, and my students. It's privilege to speak a few words about that Tech, TechMed'26 Conclave organized by the Department of Computer Science Engineering, Center of Excellence in Computational Intelligence and Medical Technology. So our Center of Excellence initiated i- in the year 2025 with a vision to bridge the gap between technology and healthcare. We are equipped with advanced computing infrastructures, modern research facilities, and a team of expert professors and researchers dedicated to innovation in healthcare technology. Today, rapidly evolving the world, the convergence of healthcare and technology is no longer optional, it is essential. The primary objective of our Center of Excellence is applying the computational intelligence techniques such as artificial intelligence, deep learning, machine learning, computer vision, data analytics to solve the real world medical challenges and contribute to the advancement of small healthcare systems. The TechMed'26 Conclave was created as a platform where the medical expert, engineers, researchers, innovator, academicians, and students can come together to share the ideas, collaboration, and develop the technology-driven healthcare solutions. Within a short span of time, our COE have evolved in strong interdiscipline research ecosystem focusing on AI-driven healthcare innovations. So one of our major achievement in our collaboration research associated with ICMR NIRT, one of the Indian premier institution working in infection diseases, communicable disease, and public healthcare research. Under this collaboration, we are currently carrying out three impactable healthcare research projects. The first project focuses on the tuberculosis prediction using the multimodal clinical intelligence. We integrate the clinical data, X-ray images, and cough sounds using the artificial intelligence model for earlier and accurate TB detections. This research aims to support the healthcare professionals in faster screening and diagnosis, especially in resource limited environments. The second project focuses on X-ray images standardizations. Since the medical image collected from different hospitals, imaging devices often vary in quality and formats. Our research development intelligent processing and standardization techniques to improve the consistency and reliability of medical image dataset used for AI applications. The third project is glaucoma detection using AI-based retinal image analysis. The glaucoma is one of the leading causes of irreversible blindness, and early diagnosis is extremely important. Through the deep learning and computational intelligence approaches, we aim to assist the ophthalmologist to identify the glaucoma at an early stage. Apart from the research collaboration, the Center of Excellence also become an active platform for the students' innovation and academic development. I am proud to mention that 12 batches of our students have successfully completed the healthcare projects under the COE. They focus on medical image processing, predictive healthcare analytics, intelligent disease analysis systems, wearable healthcare technologies, and smart patient monitoring systems. In addition, PhD research scholars are currently pursuing advanced research in artificial intelligence for healthcare and our Center of Excellence. This research contributes towards the developing innovation, reliable and socially impactable AI solution for medical domains. TechMed'26 is not merely a conclave, it is a movement towards the interdiscipline, innovation, and collaborative research. It reflects our institution commitments to becoming a engineering excellence with medical achievement for the betterment of the society. As we move forward, our vision is strengthening the collaboration with hospitals, research organizations, industries, government agencies to create a sustainable and accessible healthcare technology that can improve the quality of life for people around the world. I sincerely thank all the collaborators, faculty members, students, researchers, and organizing committee members for their continuous support, dedication in making Tech 26 is a meaningful and impactful event. Let us continue to innovate, collaborate, and transform the healthcare through the technology. Thank you.
Thank you, sir, for the outlining the objective and interdisciplinary focus of this research conclave. Strong institution flourish under visionary leadership. It is now my proud privilege to invite our respected Vice Chancellor, ma'am, Dr. S. Geeta Lakshmi, to deliver the presidential address. Ma'am.
A very good morning to all my dear students and the faculty of our Dr. M.G.R. Educational Research Institute. And of course, I thank our President, ACS Engineer ACS Arun Kumar, and our Chancellor and Chairman, Mr. A.C. Shanmugam, for giving the opportunity into education system, higher education, for all the students here, so that the institution grows up into national fame and world fame. And I thank Geeta and the mentor Cyril Raj Kumanan, who had made this effort to bring this. In fact, one of my dream was why technology is not being aligned with the medical, because the future will depend more for the assisted strengthening of the knowledge of the doctors or a nurse or a allied health science people, pharmaceutical company, pharmaceutics, anything. So which is required now. So I thank her for bringing this together. It is an eye opener. It's a starting point, first step. I think so it has to grow year by year with other departments too. So thank you, Geeta, for bringing into this, right? Right. இன்ஃபேக்ட் எனக்கு நிறைய ஐடியா இருக்கும். நான் மெடிக்கலில் இருந்தால் கூட ஒரு ஐடியாஸ்லாம் நிறையா இருக்கும். பிகாஸ் ஐ பி திங்கிங் only thing is I'm not able to do, but some people like Geeta who are able to do it. That's what I appreciate. So I want the students and other faculty members of other departments also to carry on this. So technology, இப்போ வந்து as you know, like what we were doing those days, நம்ம கிரைண்டர்லேருந்து எடுத்துக்குங்களேன், லைக் வி வேர் ஆல் அந்த காலத்தில் வி ஹேட் ஆட்டுக்கல், ஆல் தோஸ் திங்ஸ், பட் ஸ்லோலி கிரைண்டர், அது மாதிரி எலக்ட்ரானிக்கில் இட் ஹாஸ் பீன் இம்ப்ரூவிங். அண்ட் as you go on, the AI is now covered, it has come into action now, right? So without that we cannot move forward. That நீங்கள் எப்படி இப்போ ஃபோனில் இருக்கிறீங்களோ, பிடிச்சிக்கிட்டே இருக்கிறாங்களோ எல்லாரும், அதே மாதிரி இந்த ஏஐ டூல் இல்லாமல் you will not be able to do anything in future. But எப்போதுமே we have to also have at the back that we can also do manually also. That also you should think, because by electricity pona we may not be able to do anything, any PowerPoint or any kind of speech or whatever it is. You should not depend. So aduvum na solren, AI ஒரு பக்கம் இருந்தாலும் which makes your life easier. லைஃப்பை ஈஸி பண்ணுறதுக்கு உங்களுக்கு அது வருது. பட் யூ ஹாவ் டு ஃபோக்கஸ் ஆன் strengthening the other part of your life, or in your profession, or in your life. So that is what we want, because though it has made your life easy, work as well as at home, so everything has been made easy. So idhula medical la varumbodhu, what I would say is AI will not replace, but it will strengthen the knowledge of the doctors or the nurse, and it can give you it's an easy tool to diagnose, laboratory diagnosis, or a treatment module which can be specific for each patient. Each patient is different, so it can be made specific. So all this can be made through, and also new drug discovery. Today I was just talking to many things, like how a gene can be modified. So how, because since the technology has been moving forward, how a gene can be stem cell, though there is a stem cell, we can modify these gene amino acids make up in a gene, and see that the disease doesn't occur, or give a treatment for the disease. So that is what I was just talking with Ramalingam. And so there are a lot of things like which we can imagine whatever you imagine. I think so most of you இங்கே வந்து கேட்கறதுக்கு இல்லை, நிறைய பேர் ஃபோன் பார்த்துக்கிட்டு இருக்கிறீங்க சும்மா இங்கே வந்து பார்க்கறதுக்கு. ஏன்னா இந்த எக்ஸ்பர்ட்ஸ் லைக் ராமலிங்கம் and Nirmala are there. But this is not just a forum where you sit, see your phone, your thoughts are on the phone. Phone is not going to help you. Just digest the knowledge which they give you and see what you can do for the society in future. நீங்க தான்ப்பா சிட்டிசன் ஆஃப் ஃபியூச்சர். இப்போ நாங்கள்லாம் எல்லாம் போயிடுவோம், லைக் இன்னும் தேய்மானம் ஆகிடும். ஸோ நீங்கள் வந்து இந்த ஃப்யூச்சரை இந்தியாவையும் வேர்ல்டு லெவல்லையும் யூ ஹாவ் டு see some changes happening. ஸோ இருக்கிறத வச்சு இன்னும் டெவலப் பண்ணி what can we do for this society, for this. எத்தனை பேருக்கு அந்த மாதிரி ஒரு ஐடியா இருக்குது, இந்த சொசைட்டியை சேஞ்ச் பண்ணலாம்? விஜயை விடுங்க, ரைட்? நீங்கள் என்ன பண்ண போகிறீங்கன்னு சொல்லுங்கள். நீங்கள் எல்லோரும் வந்து உக்காந்துருக்கிறீங்க இல்லையா எங்கள் ஃபேஸை பார்க்குறதுக்கா? இல்லை, அவங்க என்ன சொல்கிறாங்கன்னு யூ ஹாவ் டு டேக் இட் அப், absorb them, just see what we can imagine for the future and transform your ideas into research and see that the world changes so that it makes you convenient but with societal ethics and governance. That's what I say. You have to follow the ethics. எது வேணாலும் பண்ணலாம், எப்படி வேணாலும் பண்ணலாம்ன்றது. You have to follow certain ethical values and human values when you go into the technology with in the medical science. So you have to all have all this because it deals with the human life, and you have to think about the ethical part of it and the governance part of it, where we have to lay certain criteria when you find out something or when you go in for a research. So I thank the department for giving the opportunity for me to interact with the students and the faculty, and I want other departments. எத்தனை டிபார்ட்மெண்ட் வந்திருக்கீங்க? ஏஐ வந்திருக்கீங்க, ரைட்டு. மெடிக்கல், ஃபார்மசி, ரைட், சைபர் செக்யூரிட்டி. ஸோ நெக்ஸ்ட் இஸ் இன்னொன்று செமிகண்டக்டரும் ஒன்று இருக்குது. ஸோ அதை வச்சுட்டு ஈஸியும் இன்வால்வ் பண்ணணும் நீங்கள் இப்போ, right? You have to involve the ECU also. So think life become, I mean the research becomes still more useful. That's what is my last word. Thank you all, and I want all my students, right? எத்தனை பேருக்கு இங்கே இருக்கிறதுக்கு ஃப்யூச்சரில் இருக்கணும்? நான் எப்போதுமே என்னோட டாக் முடிஞ்சோன்னா அதுதான் கேட்பேன். எத்தனை பேருக்கு இந்த சொசைட்டியில் சயின்டிஃபிக்காக மாற்றங்களை கொண்டாடணும் அப்படின்னு ஒரு ஆசை இருக்குது? ரொட்டீனாக இருக்கக்கூடாது. பசங்க கூட நீங்கள் விளையாடலாம், ரோட்டில் பைக்கில் சுற்றலாம், ஃபோனை எடுத்துகிட்டு சினிமா பார்க்கலாம், எது வேணால் பண்ணலாம். ஆனால் மாற்றங்களை கொண்டாடுறதுக்கு நீங்கள் என்ன பண்ண போகிறீங்க? யாரும் ஒன்றுமே சொல்ல மாட்டேங்கிறீங்க. ஒருத்தர் 2 பேர் இருந்தால் கூட போகிறோம் இந்த உலகத்தில், இந்த இன்ஸ்டிடியூஷனில், ரைட்? ஒன்லி ஒன், 2, 3, 4 போகிறோம். 2 பேர் இருந்தால் தேங்க்யூ கைஸ். ஸோ மாற்றங்களை கொண்டாங்க, நீங்களும் முன்னேறணும் என்று சொல்லிக்கொண்டு விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you, ma'am, for your inspiring and motivating address.
It's now time to introduce our esteemed chief guest for today's inaugural ceremony. To formally present his profile, I invite our student representative, Mithila from 3rd year BTech SC, to kindly come forward and introduce our distinguished chief guest to this guest gathering.
Good morning, everyone. It's a great honor and privilege to welcome our distinguished guest, Dr. Ramalingam, Scientist F in Immunology Division at ICMR NIT Chennai. Dr. Ramalingam has over 26 years of extensive experience in molecular and cellular immunology with a strong focus on innate immune responses in infectious and inflammatory diseases. He completed his master's degree in zoology from University of Madras and earned his PhD in biomedical science from ICR NIT Chennai. His global research exposures include prestigious institutions such as Institut Pasteur Lille, Columbia University, and Feinstein Institute for Medical Research. Sir's research contributions are centered on understanding host immune responses to mycobacterium tuberculosis, including monocyte subset, nutritional immunology, host immunogenetics, and transcriptomics. His work has played a crucial role in advancing tuberculosis diagnostics and immune-based therapeutic strategies. Dr. Ramalingan Sir's excellence has been recognized through numerous prestigious awards and fellowship. He was awarded the Ramalinga Swamy Re-Entry Fellowship by the Department of Biotechnology, Government of India in 2014. He also served as a senior key personnel in NIH-funded research project in 2010. From 2006 to 2009, he received the New York Sile Foundation Basic Research Fellowship for his remarkable work on lupus nephritis. Earlier in his career, he received the IFCPR Postdoctoral Fellowship in France in 2003 to 2005, along with Edge Fellowship for International Studies in 2001. He was awarded CSI Senior Research Fellowship in 1999 and qualified the JRF NET in 1996. Adding to his academic excellence, Dr. Ramalinga Sir received the Jawaharlal Nehru Memorial Fund Prize for Science and Technology in 1994. He was also awarded a gold medal for securing first rank in his Bachelor of Science degree and received the General Proficiency Award during his undergraduate studies. With such an outstanding academic and research journey, Dr. Ramalinga Sir continues to make significant contribution to the field of immunology and global health. Today, we are truly privileged to have such an eminent scientist among us. So let us give us a round of applause and we extend a warm and heartfelt welcome to Sir. Thank you.
Thank you, Mithila, for the wonderful speech. To express our heartfelt gratitude, I request our Vice Chancellor, ma'am, on the dais to kindly felicitate our esteemed chief guest. So we sincerely thank you for the gracious accepting our invitation for being the part of this prestigious occasion. The inaugural address the mark of official commencement of this conclave. I respectfully invite our chief guest, Dr. Ramalingam Bedunayakan sir, to deliver the inaugural address. We are also honored to have another distinguished personality with us. To introduce our esteemed guest, I now invite our student representative, Nivedita from third year BTech CSE, to kindly present the profile of this guest gatherer.
Good morning to one and all present here. It is my great privilege to introduce our esteemed chief guest, Dr. S. Nirmala Devi ma'am. Dr. S. Nirmala Devi is a professor in the Department of Biomedical Engineering at College of Engineering, Guindy, with extensive expertise in medical image processing, biosignal processing, artificial intelligence, and rehabilitation engineering. She has successfully led several prestigious funded research projects supported by the DST and DST SERB, including real-time EMG pattern recognition for prosthetic control and innovative healthcare instrumentation systems for disease detection. Her research contributions have greatly benefited both medical and rehabilitation fields. She actively collaborates with renowned institutions such as Tamil Nadu Veterinary and Animal Sciences University and Government Institute of Rehabilitation Medicine, reflecting her commitment to interdisciplinary research and societal impact. Dr. S. Nirmala Devi has received numerous recognitions, including the CIPR Best Project Award, Best Paper Award, and High Impact Factor Award. She has also guided several PhD scholars successfully, contributing immensely to academic and research excellence. We are truly honored to have such a distinguished academician and researcher with us today. Her achievements and dedication continue to inspire students, researchers, and professionals alike. Ladies and gentlemen, please join me in warmly welcoming our respected chief guest, Dr. S. Nirmala Devi ma'am. We welcome you, ma'am.
Thank you, Nivedita, for your remarkable words. I request our Honorable Vice Chancellor, ma'am, to kindly felicitate our respected Chief Guest. Strong academic foundations are built through visionary leadership, dedicated administration, and continuous guidance. I now respectfully invite Dr. S. Cyril Ratza, Additional Registrar Academics, to kindly address the gathering and share his valuable thoughts with us.
Hello. The most respected Vice Chancellor of our university, respected Chief Guest, Dr. Ramalingam, Scientist Chef from National Institute of Tuberculosis Research, a unit of ICMR, respected Dr. Nirmala Devi, Senior Professor from College of Engineering, Gindi, Anna University, faculty friends and beloved students. Our university is a deemed university, all of you are aware. We have 14 different faculties in the sense 14 different colleges are there in our university. So most of the people who visit our university or the government of India expect interdisciplinary initiative or research or a dialogue or a project. These are some of the important expectations from our university. So in all our initiative, we are right now focusing on how to bring various various faculty, departments together. So this is one of the best example also. So whenever any dignitaries visit here, they ask very simple questions. How many programs are inter-faculty programs? That is, multiple faculty together running one particular program. So in fact, we have initiated biomechanical engineering, but we could not able to take it off also. Many such proposals came, but we could not able to make it up. So one of such proposal is this Center of Excellence, the computational intelligence and the medical technology, where the engineering fraternity, that is the Department of Computer Science, is right now collaborating with our medical faculty. Dear students, friends, you should be aware, our university is right now having a tag as a medical university also, because among the multiple number of departments, the number of departments as well as number of students from the medical fraternity as well as from the faculty members also, those numbers are very big. So these are the right senses. Dear students, friends, right now we are in the era of disruption of AI. So without AI, definitely we cannot have regular day-to-day activities also, as what we have seen as a disruptor through the mobile phone and then through the computers in our days. So right now it is the AI is the disruptor. Students, you are aware, right now the number of doctors in our country are 1:1,000. So that is the barest minimum number of doctors which the WHO standardizes. But rather, in many of the country, I'm talking about the third world country, as well as in the developed countries also, the number of medical professionals are very, very less. So if that is the case, unless AI is assisting them, the AI, for example, nuclear, when an image like X-ray or a MRI or a CT, all the things are taken, there should be a secondary eye along with the the radiologist or the doctor who prescribes that particular diagnosis procedure need to augment or bring down the time involved in the diagnosis is also very important, and then the time of diagnosis, then how quick the diagnosis process are happening. So many such things are there. And then again, when after the identification of the disease, when the prognosis of the disease takes place, so definitely AI is playing a very, very important role. Right now, most of the doctors are taking their help with the latest research across what is happening there, and then how latest medicines are being prescribed across various conditions also. So many such developments are happening there. So with the proper integration of these the prognosis process with the AI will definitely value add. At the same time, as already I told you, the country like us, where the medical doctors per 1,000 people nuclear are only one. So if that is the case, there will be a long queue for experts to be visited. So there also, for managing the medical resource persons also, the AI is playing a very important role, like pre-screening through AI, as well as taking their appointment. All the things nuclear can also be streamlined through the AI also. The same way, even the cancer disease diagnosis, and then all these dreaded diseases. I think right now there are a lot of new diseases which are coming, like the zebra disease, something like that, where only very few patents are available there across the world also. 1 in a million, something like that, such a disease are happening there, but there is no trace of what is happening across. But if you use AI, and then the other, the other part of the world, though, those people have started using the AI, so definitely there will be a integration of knowledge in handling such a very rare combination of diseases also. So dear students, opportunities are very imminent. So the thing is how you are ignited to explore interdepartmental opportunities. So that's what actually these are the platforms. So try to make use of these platforms so that you will be different from the rest of the other your colleagues also. So this is the need of the hour. So this is how we have to project our country as one of the superpower in all in both knowledge as well as in other areas also. So I thank first of all I have to thank our President sir for providing such a wonderful opportunity. So the moment we said we wanted to establish as a center of excellence, he said go ahead, whatever the facilities that you need, take all the things. And then I have to thank our Dean Engineering Technology, as well as the head of the department, Dr. Geeta, and then Dr. Kumaran. So these are the people who are in the limelight of this particular initiative. I hope and then believe this interdisciplinary research center will be a nodal center for many such new developments in the coming days. Thanks a lot.
Thank you very much, sir, for your insightful and encouraging words. Your guidance and support truly inspire us towards academic excellence.
I now respectfully invite our chief guest, Dr. Ramalingam Bethanaikan sir, to take over the dais and share his valuable thoughts with us.
Okay, so good morning, everyone. Good morning. So it gives me an immense pleasure and nice opportunity for me to interact with you all, particularly in the field of computer science and technical educations. And I thank the opportunity given by the organization, Dr. Kumanan, and the organizing committee for giving me this opportunity to share some of my thoughts where this AI can be utilized in the field of medical research. And we being a researcher in the medical field, so we always feel there is a lacune and there is a need for superhuman thinking, where that now is being replaced by means of artificial intelligence. Lot of procedures, thoughtful procedures, are very much time consuming and labor intensive. So these things can be very easily achieved by means of having this artificial intelligence. And particularly like when we incorporate the multidisciplinary approach, particularly from an engineering background or from a medical paramedical background and from a computational background, when people try to understand the concepts of medicine, then it will be much more helpful. As Sir said, the ratio of doctors to public civilians is very, very high, 1:1,000. So imagine if one person is going to cater 10 people or 15 people per day, then how long he is going to have that one cycle of 1:1,000? So everybody should not be confirmed or confined towards their own domain. We should see that, as our Vice Chancellor clearly pointed out, what do you give back to the society is the biggest question. See, everybody, we all work, we all do learn, research, we survive, we take care of ourselves, our family, our society. But at the end of the day, what do you contribute to the society is much more important. So we feel we are doing some research. The benefit and the outcome of the research is going to serve the society for a better medicine or for a better treatment or a better understanding of the disease. So similar concept has to be inculcated into you people, where you are all younger generations now. Now, if you ask what is your ambition, you may have to have a car, a house, a beautiful partner, a profession, then what? So ultimately, you have to think the ultimate thing is how do you contribute your knowledge to the society? And I feel you are all lucky to have a nice educational institution where they have put a medical background along with an engineering background, a medical person who can make these interdisciplinary actives in an active manner. And this gives an opportunity for you to work and understand the concepts of various technology and understanding the roles of AI in a different manner. So in abroad, it's very easy to an electrical engineer can go and do medical degree in a couple of years. But here it is our education system doesn't allow you to do an interdisciplinary research. So rightly now it's slowly coming where you people have to decide where you have a domain to work. Being a medical person or a non-medical person, how to contribute in the medical field. Everyone will be associated with some of our family members with some sort of disease. It can be a communicable disease or a non-communicable disease. The non-communicable disease is much, much more among the human beings now. So where lot of people, they do not know how to diagnose, how to understand, how to interpret, and how to go ahead with the treatment. So everybody has to understand the biology in us. And I don't know whether all the computer science students, you should have at least studied biology in your plus one, plus two. There are a now definite group which excludes the biology from the plus two, and it's purely basic on psychology or with computer science. But that kind of understanding is very essential. And if you don't understand the biology of yourself and the human beings, it'll be very hard to manage the future. And in the future, it is all going to be AI driven, where the knowledge is not going to be a resource for you alone. Imagine a professor, he is taking the classes. AI can come and remove his job, he can come and do it. But what is going to control the AI? What AI has to be taken, basically, it is the medical aspects, particularly the humanity, ethics, and consciousness and skill. These are all the only components where AI cannot take it over. So, for that purpose, what you should think is this discipline of medical research is a very fantastic domain where AI can be pitched in, because we have a lot of data, but we do not have enough knowledge to interpret the data and to document the data. So that is why here there is a bigger need in the AI, particularly in the medical research and health component. There may be multiple options in the business sector, other management, and all those things. But beyond that, where it has a direct uh, intervention and direct benefit to the society is only through medical research. So today in this talk, I am just going to let you know very few basic opportunities. Where are all the field where AI can have a bigger role? So this may be a small spark for you. Just get the terms what you know and try to implement in the projects. If you have an opportunity to do a small project in health research, please take it up and see how you can do. And once you have accomplished a small component, then you yourself will be inspired to do a lot on the medical research. Okay. So with this few things, I just go to the next one. So these are all the basic points which I would like to summarize, and also to say that these are all the avenues where you can really contribute to the topic of AI. This is the demand, and right now this is the area where AI is edging the researchers. So I would like to see out of this 10, if anything one is interesting in you, then it will be happy for taking it up. Okay. So I am just design my talk based on this 10 points. I will go for a couple of slides with the known diseases what we have experienced as a disease burden. Hmm? So just to summarize here, it is like a health research foundations, then comes the diagnostics, then the medical imaging technology, then comes the drug discovery and treatment optimization. There is the genomics research and precision medicine, then NLP, surveillance and epidemiology, then predictive analysis and outbreak forecasting, then ethics, bias and regulation, and finally few careers in the field of AI. So this is just an eye-opener kind of thing where I would like to uh, introduce where these fields can be very helpful for future research. Yeah. So before going into the AI, I just want to show that there is a bigger disease burden in the society now. So as I said, the communicable disease and non-communicable disease, they edge everywhere. And among those diseases, there are very few communicable disease, which is very hard and challenging to eradicate. So one such is tuberculosis. See, next to the COVID, the highest, largest infectious disease is tuberculosis, which kills almost 10 million people per year. And it is highly from 95 onwards, we would like to eradicate this disease, but it is coming up in a different form. So this TB has a bigger challenge. We do not have a better vaccine than BCG. So the prevention strategy is not there. and it is all over the place, like particularly in the endemic countries like Southeast of Asia and then Africa, where the larger population is there, we have a biggest problem in eradicating this disease. Then the communicable disease, what you would like to see is the cancer. Cancer is evolving in a different form, like wherever, it is not a single tissue or a site of organ where it is getting cancerous. Now every part of the human body is being mutated and it is prone to become a cancerous tissue. So this is a human challenge or the medical field, like how to diagnose it and how to intervene and how to prevent it. So this remains the biggest challenge where AI has an important role to tackle it in a better way. Then comes the sepsis. See, sepsis is a very trivial conditions. Those people who have gone to the ICUs, they know that they come for a different purpose, and then they end up in ICU for different purpose, but they die for a different cause. So this sepsis is another important issue where our body reacts in a different manner so that our inflammatory systems gets exacerbated and it causes a sudden death where we cannot predict when he is going into a sepsis mode at all. So this is a very challenging medical conditions where human minds cannot anticipate when it is going to happen and how it is going to be handled. So that is the very biggest challenge in the medical field. Then further, it is an AMR infections. It is an also a down-driven fact of sepsis, where you can see that generally we just go take any antibiotic and use it. Left and right, we are using it. We go to the pharmacy, or even for a sore throat, we take an erythromycin and then put it down. But in future, when you take it a couple of times, what happens is your body prepare resistance for those kind of antibiotics. And the next time, 10th time, when you put the same antibiotics, you don't see that it is working anymore. It is the same pity conditions where the AMR is now getting more and more developed. And you see that these things are handled only by AI mediated antibiotics. So that is why we need to really see that how this AI can be applied in some of these kind of diseases. I have taken these 4 disease model as conditions, and then I will go through the opportunities where which is very much needed. Hmm. So now we go for the foundations of health research, and now it is very technical for you people. So ML taxonomy and applied renal diseases, how is it going to be happening? So the basic foundation and understanding of AI, I think you people will be technically more knowledgeable on these factors. But basically, we can categorize into these 4 platforms where it introduces the supervised learning, unsupervised learning, reinforcement learning, and LLMS foundation models. So these are the very, very essential things. We have enough data, but the input and output of the data has to be very clear in our mind. So a lot of people are spending more time in generating the data and leaving the data. So that is not going to help you. This data has to be structurally presented so that another person can work on the structure. So this supervised learning is a very important characteristics of AL, where you can say once you give an input, the output can be delivered in a very dissected and delivered manner. So that is called a supervised learning. And where, on example, what we can do is the diagnosis of TB spectrum. So once you have a sputum, you stain it, and after staining, you just give it to the microscope. The microscope will find it and tell where there is a bacilli or not. So this is a trained supervised culture reading. So we need not have a microbiologist to go and search the TB in the sputum. So this is technology is going to replace the microbiologist. He doesn't want to identify a pathogen and say this is mycobacteria. So now the computer and AI can tell them that this is already a mycobacteria. So this is one touch example where it is replaced in a lot of places. For example, in India, we are all affordable. So we have a nice primary health center where a microscope is there. But in countries like South African countries, where there are no microscopes, the people cannot have a sputum smear microscopy done at all. Second thing is, there is no trained education for microbiologists to identify the bacteria. So what they do is, simply they take it, develop a program with the AI, and it can clearly differentiate the mycobacteria and the sputum, whether it is there or not. So simply it can do the reading, and it can replace with a sensitivity of 95% above. So this is a very important thing in the field of TB, where diagnosis is being taken by the means of fine. So that is in terms of things. Then second thing is, after the supervised learning, there is another unsupervised learning. So this unsupervised learning is just like you, what you know, what you do, like you learn by yourself without a guide, where the input data is plenty, but the output you have to instruct them what to give as an output. So this in the unsupervised data, what you see is there are a lot of regimens and diagnosis patterns are different. So you want to see for TB, like whether the diseases he is become a TB resistant patient, and for what conditions he has become resistant. For that, we have to do the DST, phenotypic and genotypic analysis. After having the genotypic analysis and phenotypic analysis in a different manner, you cannot decide which is the disease resistant which is causing the resistance pattern. So for which, like the phenotypic of M.G.R or X.D.R patients, they can be very well classified only based on those kind of AL mediated techniques. Then comes the reinforced enforcement learning, where what you have to do is you have to educate the AML. So I mean the machine learning, and say under the clause of some things, like if you happen this, then what is the cause and effect? And if this has happened like this, then it is what is the cause and effect. So you keep on repeatedly enforcing the data, and then you get the details how it is going to be helpful. So that is called reinforced learning. And finally, the large language models, where you can have the exact of whatever you have. See, I have a patient in a clinic where is 50 TB patients come, and end of the day, like I want to know who are all drug resistant, how many of them are taking medication, how many of them in the screening mode, and how many of them are completing the treatment. So all these things can be extracted from the database, and it will be given to you in a concise manner. Those are all the LLMs, and this is also very helpful in disease control mechanisms. Pointer angaya. Yeah, next slide. Fine. Yeah. So as I said, fine. Fine. So this is the diagnosis side, what I have told exactly. So it doesn't mean only in the case of microbiologists in the form of identifying the bacteria, but also in the form of chest X-ray. And this chest X-ray is the biggest one, where I think a lot of people in your department, Dr. Kuman and others, are working on, where the chest X-ray doesn't have the capability to differentiate the diagnosis, but it has the only eligible conditions to test the diagnosis. So what you have to understand is how this chest X-ray can be easily read. So there are specialists in the field of radiologists who has to sit and read the X-ray. And if you give a trained X-ray person and another radiologist who is untrained, they come up with two different interpretations. So these things are going to be challenging conditions. So we need to have a neutral umpire where he says, these are all the normal X-rays, these are all abnormal, and this abnormality can be of much helpful towards identifying the treatment. Now, a lot of softwares have been already developed, and hospitals like Apollo is already having the chest X-rays, where the chest X-ray is taken and put it in the computer, and then the AL automatically says, is there any lesion? And this lesion is related to TB, or it is not related to TB. So that kind of diagnosis is made within a period of seconds, and then it will automatically give, and then the radiologist, he is happily sleeping at home, so there is no need to bother the radiologist at all. Or the pathologist can immediately give a report and say he is suspected in the case of TB medicines. Then other thing is like the gene expect and triage causes. So in ultimate, what happens is we need the TB to test whether the bacilli is there or not. So we need advanced machines, and each machine is all developed by abroad. On one cartridge, it takes 1,500 rupees at least. So just like that, you cannot decide whether we need to spend 1,500 rupees on the patient. The out-of-pocket expenditure for the patient is very high. I cannot simply go and say, okay, you take this test, gene expert test. So you have to shell out from your pocket of 1,600. If you are not spending, the government has to spend 1,600 for everybody. So there is a clause now which AI can help you whether you need to take the test or not. So that is the important thing. Now AI is being interpreted to see whether this can be going for the next level of diagnosis to have a confirmed diagnosis. So this kind of intervention is not only driven for diagnosis, but also has a economical impact also. And this is why we do not want either the patient or the government to spend more money on utilizing the cartridges. And similarly, the lung versus other conditions. In the lung, you have shadows, and we think the shadows are all only because of TB. No, never. If you have any fibrotic conditions because of smoking or because of any other infections or pneumonia, everything will cause a shadow. But how to discriminate this shadow from other diseases and TB disease? It is the biggest challenge. So we have to develop some amount of tools to see that what can precisely say it is TB or non-TB or any other lung fibrotic disease. So these are all the areas it is still a medical challenge, and it can be resolved only by means of AI. Then in the terms of cancer, again same thing. So cancer mainly in the terms of either the breast cancer or the prostate cancer. These two are the areas where human is much more prone to get cancers because they are very soft tissues where thermal regulation is more and easily the cells can is vulnerable to get into the cancerous mode. So, but diagnosis of these two things are very, very tough because they are all soft tissue where the nodes and the cancerous cells is very hard to discriminate. But this imaging technology is one of the available technology where we do not have any other method in a non-invasive manner. So where is a imaging is a better or only available option to diagnosis. So we need to develop much more precise enhancement of technology in the terms of prostate cancer or in the breast cancer. So these two areas becomes very challenging. And then the colorectal polyp detection. So once you have a colonoscopy or an endoscopy, we need to find, and only an experienced gastroenterologist can see where is a polyp or where is a dip in the epidermal region. And these things can be identified much earlier because we can see when you do a colonoscopy or endoscopy, they just look for an obstruction and they look for any obstruction where it leads to bleeding. But they will be missing lot of polyps which develop into a cancer at a later point of time. So now AI being used to see whether these polyps can be identified in a earlier stage, and this can be taken off by means of biopsy, and then we can test the thing. So these advancements in the imaging technology is handled only by AI nowadays. So that it in the cancer also it is much thing. So now what we go next is the medical imaging and the deep learning, where we can see that these are all the various platforms which is really now existing in the medical field. So most of them we do not know. We think that this is not there and we are aiming to achieve this in a different way. So these medical platforms already runs on AI platform and makes the life of medical people easy. So what are all the special things is the ResNet and DenseNet. It is all for the trained NIH chest X-rays. This is developed by the FDA and it is all running outside. The problem there is the patient ratio is very less and there is a clear demarcation of TB and not TB. So it is very clear and the ratio of people coming to the clinic is very less. So this can be having a more sensitivity and specificity. But countries like in high endemic countries like India, there is a spectrum of disease. A person comes at an early stage, a person comes at in between stage, a person who comes at the very later stages. So differentiating the severity of the disease is being a real challenge. So there it is yes or no is very possible because it is only dichotomous. But we have an intermediate clause which has asymptomatic, symptomatic, and then comes the latent, then comes the drug sensitive, then comes the drug resistance. Your spectrum of condition is there where the severity goes from high to low or low to high. So this is the place where AA can play a role. AA gets confused. He wants to know whether it's yes or no. It is very easy for it to say yes or no. But in between, if you ask where he is, what is the scale of 1 to 10, it is very highly demanding to challenge. So that is where the you trained people have to decode the stages from 1 to 10 and say this is stage 2, this is stage 3, stage 4. So which needs more data sets and more knowledge on the X-rays and more outputs from the clinicians. So when you integrate all these things, it will be very easy to diagnose the challenging aspects. Then vision transfer, like cataract or retinopathy or myocardia things, whatever, whatever membrane related orders in the retina. So those can be easily scanned by means of imaging technologies. It is already implemented. Our Shankara Nethrayal is also having it. So this is very basic and essential tool now. AI is only dependent for cornea related activities. Yes, yes, yes. Yes, unless we go to the clinic. So now what we say, as long as I see here, I say I am fine. Only when I don't see the knob or something, only then I go. So if we do it on a regular basis at an early stage, the diagnosis become much earlier and easier. So that is why we are not standardizing, but these are all FDA approved and it's all in action abroad. And here also they are trying it with validity. So what we have see is these are all available here also, but on a cost of bigger expenses. Only a cost hospital like Apollo, they are afford to have these things and making use it. But we are not using it for research purpose. We are using only for the diagnosis and tertiary care hospital. But when it comes to the research and it has to be validated in a bigger platform, then it can be easily taken to the public health sector. So that is why we need more research on the AI to make sure that whether these tools are helpful or not. Yes, we have a separate division on this on health diagnostics, where we are also working on these things and improving. And our job is to validate these tools and see whether they are really having. We have a strength of having the data in our research domain. We use this data and see validate it and say whether they are really helpful and whether we rely on it, and then we can invest on those things to make the diagnostics in a cheaper manner. So that is one conditions what we do. Next slide. Okay, it is going to the updates. Yeah. Yeah, then comes the drug discovery, and this is a one biggest thing. So I don't know how many of you have an idea. So how long it takes to get one drug effective? Any idea? At least 10 years. So unless and until you identify a drug as a molecule and then take it to the different stages, it takes really 10 years. And these are all the various stages of uh, process where every discovery is being taken into an account as a drug, and you have to finalize which whether it is the drug is important or not, whether it is working fine or not. And this takes enormous time. And the initial stage, like a target identification, hit discovery and all, it takes years and years together. And now AI has replaced it. There is one program called AlphaFold 3, which does the drug target identification, where you want can run multiple compounds and see the binding sockets, the energy levels of bindings in a couple of hours. Earlier, it used to run for 2.5 years or 3 years, now we have a GB based high throughput computers which can do it in the help of AlphaFold within 24 hours. So if you have a molecule, you can decide whether this molecule can go as a drug target or not in 24 hours. Earlier, we used to struggle it for 2 years or 3 years or even 5 years to see that what are all the molecules it can come, what are all the combinations it can work, and how this can be taken up into the research industry. Now, this computer, this AlphaFold, does it in a overnight and say whether your molecule is fit to be a drug or not. So that's kind of an advancement is there, and a lot of pharmaceutical companies are relying on these kind of targets. So if you can get an opportunity to work on those kind of platforms, it will be very ideal for you to say that there is an opportunity to identify a drug target at an early stage. After identification, then you have to see the hit discovery, like where exactly it is binding and how it is going to mobilize the drug and whether it will be functional or not. Then comes the lead optimization, where you have to say an additive compound to the existing drug can help you in a better efficiency. Then comes the preclinical model and clinical trials. See, this preclinical model is also now we have to spend more time in the lab with the mice or rabbit or rat and inject them and wait for 6 months and then to see whether they are active or not. So now AI is working for you that also. No need to introduce it into the drug and say that whether it will work or not, that kind of decision can be taken in a very advanced stage. If you are clearing that and regulatory saying that this molecule has an effect in an in vivo system, then we can spend money on the research and spend more time on a higher mammals and see whether it is working or not. Similarly, on the clinical trials, there is a bigger data of clinical trials where the drugs are going exposed in a different level. If you are very clear with a molecule, you can always go back to the other clinical trials which is already done with the same molecule, and you can say whether this compound has a additive effect or regular effect, and you can say whether you want to spend crores of money to conduct a clinical trial. So this is an advanced technology where the drug related issues has an importance in AI, and this can be challenges can be removed by means of advancing the AI. Then other field is the genomics, resistance and precision medicine. So as madam was discussing, she was telling there are some point mutations and single mutation which can cause a phenotypic diseases. So those things can be easily identified, and now there are new technologies like CRISPR-Cas technology, where in the sperm or the egg itself, you can change the mutations. And these mutations can be deleted, and then the offspring can be having a completely divide of those genetic diseases. This is all the advancement. But how do you do the advancement? You have to screen millions of sperms and millions of eggs to find an egg which is without divide of the mutation. And that kind of screening tool is being given by means of, educated by means of the AI model. So these two examples, what I have here is the TB and the cancer. So in the TB, what we do is, see, these are all the different platforms where all the TB bacilli, whatever we isolate, has been sequenced. It has 4,000 genome pattern, 4,000 MB, and it has like different genes, and these genes has been mapped out by means of whole genome sequencing. And from that, what we have to see is which is a definite pattern and where it is resistance and how is it doing it. So in our institute, I'll tell you one small incidence where we used to collect the patients and then we run the whole genome sequencing and see what is the type of the bacteria which is isolated from the patient. So luckily what happens is 116 from day 1 to day 30, the 16 isolates were of similar pattern. Then we thought why it is similar pattern. Then we went into the Stanley and other Chennai Corporation hospitals, and then we found out the 16 patients isolated from North Thondayarpettai. Then what we did was we just put the GIS into it and found out where this 16 cases are located. And we found out in 2 streets of Thondayarpet, 16 people were identified to be a TB positive, and then they have been isolated, and this all spread from one TB bacilli. So this was biggest outbreak investigation what we done in the recent, where GIS was the biggest support for us, and the matching of AI patterns like in a RedSeek and other pipelines. It's all AI driven pipelines. Will say the bacilli is same or not, because if somebody comes here and spread it, then that bacilli will go to the other person, and somebody from the other infected person, he may get a disease from a different person. He cannot say because of this patient allowing the one patient here, I am getting diseased. So this kind of ethical issues and tricky issues can be resolved by means of having the AI tool. And similarly, this can be very helpful in the case of cancer. As I said, the single cell RNA technology. So we all know that a small cell divides to a big myeloma and then cause the cancer. Unless and until you know what is the genetic background of the small cell, it is very hard to control it. So we have a detection system and some markers like PD1. If a cell has a PD1, then you can give an immunoregulator. This PD1 will go and directly bind the PD1L1 ligand and clear the cancer. So that is why if anybody comes with any cancer, they will take a biopsy. The first thing they will check is look for PD1. If PD1 is there, you are lucky. They will always give a immunoregulator, which is a little bit expensive, and directly goes and kill the cells. If these kind of genomics patterns are not there, then we have to keep on switching the alternate mechanisms. So genomics and precision medicine, which is varying different cell types, are being handled by AI tools nowadays. Then comes the surveillance and epidemiology. As I said, this is large language models are multiple efficiencies, and epidemic prevalence and intelligence, and also the surveillance. So these are all very important aspects for any disease. For a communicable disease, surveillance and epidemiology is important, but for the other disease, it is not there. So I tell you on another story for this epidemic intelligence and outbreak. Last year we had a very funny incident in Maharashtra, where people in a particular village suddenly they were bald, both ladies and gentlemen. They were losing bunch of hair in their head. Suddenly, like they started coming to the clinic and say reported, our hair is falling, and then we do not know why it is. And so then we were triggered from ICMR, and then we have to go and experience them and then see what is the cause behind it. So we took the blood samples, we took the soil, environmental, everything, and then what we did is we want to go and give it to the CDRI Lucknow to see is there any drug present in the affected patients. Then when we did multiple assays, then what we found out is selenium was more in all the patients. So this selenium is a mineral which has been beneficial to certain level. When it goes beyond that, you will have this toxic effect. So then our next research was how does this selenium came into the human beings in a exorbitant levels. Then we went around the environment, their food recall mechanism, and then we collected the samples of what they eat, grains, everything. And finally, we found out the public distribution, the ration shops distributed 5 bags of wheat from one procured from Punjab. And that Punjab, they have spread more fertilizers which contained more selenium. So this selenium went into the soil. From soil, it went into the wheat, and wheat it come to one of the pockets of Maharashtra, and the village which got those 5 bags of wheat were all affected. So this is a very important investigation from ICMR. We same, and then we identified it is only because of selenium toxicity. This was an issue. But to track all these things, we have to spend more amount of HR, more amount of money, and more amount of investigations. So now what we have fed is in a blood health report, the trace elements, capacity levels, everything is now feeded. And we have taken it in the considerations of all the samples. We have collected almost like 80,000 samples. In this 80,000 samples, now we fed the data and we have asked the AI tool to see the abnormality in the trace elements. So collectively from 80,000 samples, it picked out the 180 people who had the bald. So this is after getting the result, we went back and then we feed the program, and then we know that when the levels of selenium are above this, then you have this phenotypic effect. So such a kind of knowledge has to be developed by the researchers, and that has to be incorporated and put it into the machine learning, and now they have to tell you the outcome effects. And this is not only restricted for those diseases, it can be for a normal human being also. So when you have the same levels of trace elements up, luckily like in our blood diagnosis we do not do that, but when we do a diagnosis with all these elements, it can clearly show it whether they are all toxic, or it can tell you that you are going to be having a phenoterious, a deleterious effect at a later stage. So this is a small healthy tip where AI can play a bigger role, and you people should be like, seeing this. So sometimes we think the only AI is good for lazy people so that they can sit and think what they want. It is not like that. It may be lazy for you, but it is a need for other people also. So that is why we need to be thinking what you can do and how you can do to the society. Yeah, this is about the outcome of this one, and it is already the risk score, early warning, and outbreak forecasting what we have done. This can be in the TB treatment, sepsis, cancer, cardiovascular, and diabetes. And we have used a lot in the case of COVID-19, and then the transmission mapping, we have done it. Then comes the ethics, bias, regulatory frameworks. So this is where it is very important. Our AI doesn't have the knowledge to discriminate based on the bias or not. Whereas the human beings, we have that bias. We can say, oh, this is not for them. This is only for them. So that kind of discriminating capacity and ethics and our emotional IQs come in a major decision making mechanism. So this decision making will have ethics and bias in the background, whereas the AI will not have the same thing in the background. So considering this, AI has an important do for important like a geriatric medicine or the terminal diseases. Lot of things can be decided, and also like one tool what you develop can be varying because of the data what you put. Suppose it is developed only in the Caucasian population, we cannot help to see that happening in the Indian population also. So we need to be very conscious in applying these things and see how the ethics and the bias can be removed. So some examples are in the TB graphics where the sensitivity can be dropped between the Indian terrain and the South Africa people. Yes, other countries are there, and here also we see it in a very affluent population. Yes, small boy, if a boy comes and say he is having stomach ache after having milk, we will go treat it and then we'll say he is a lactose tolerant. But a non-affordable population, they don't even go there. They think by having milk, I am not having, I am taking thing. But that will come in a later stage. So affluent people who can go it and diagnose in early conditions, they are aware of it. Whereas lower static people, they don't even are aware of this thing. So awareness is very important towards identifying these kind of disease in an early time point. Yes, yes, yes. Allergy is also there. So we think, we are not allergy prone and we are not having anything, but we takes it in a different doses and a low dose. Some people like, for example, in America, I had a lady, when the rice was steaming, she just came and smell it. Then immediately she got into type 4 reaction. Then we were worried what is there in the rice. But then later we came to know it is the arsenic of compound in the rice can create allergy for those people. They are all Hispanic people and Caucasian people who never take it. And similarly, this arsenic is there in the prawn shell also. So for those people who take the seafood, they're all succumbing for the arsenic problem. So these people are, when they identify earlier in a lifetime point, the shock is going to be minimal. But when they progress without the knowledge of all these things, they will have a later incumbency, and then they will have a fatal end. So those are all the diseases which are mainly in the bias ratios. Then what it is called this the explainability in the medical conditions. So sometimes the medical people, they themselves do not know how and why this is happening. For that kind of scenarios, AI has a bigger role. And for some examples, like, basically what you can see here is like some of the concept based test, and then some of these sepsis kind of things, and cancer boundary pathogen. So they know there is a cancer, but what type of cancer it is and how this can be identified and what can be decided. So this kind of intrigue knowledge of medical people, they need the support of medical and non-medical and computer aided diagnosis. Then comes the regulatory medical framework. Like with the AI, you cannot go and do whatever you want. So there are some regulations, and these regulations are framed across the world. And there are multiple frameworks where you can say whether it is possible or not. And these are all the various products. And particularly in India, we have the CEDESCO and ICMR guidelines for ethical AI. And for the US, they have this HIPAA. See, for example, we also have a hospital, and we say that we have a patient. Then one person goes to the patient and says, காலையில் வந்த பேஷண்ட் இருந்தாருல்லம்மா, அவருக்கு என்னம்மா சுகர் இருக்கா இல்லையாம்மா அப்படின்னு கேட்டாங்கன்னா, டெக்னீஷியன் will say, சாமா சார், அவங்களுக்கு 300 இருந்துச்சு சார் காலையில். So this is not an ethical reason to do. A person comes to you for a clinic to test his patient, and his identity has to be protected. And nobody is supposed to reveal the dangerous conditions. If it is a really alarming condition, it has to be revealed to the doctor and to the patient who is concerned. We as a general public, or in the person who handle the medical lab, we are not supposed to spread it across. This is a point of a regulatory rule in America. It is being protected. So where at least 20 or 30 point parameters is influenced on every patient, and it is very often hard to decode the value of the patients. So those kind of regulatory rules are there in the AI, and then this can be fed into AI, and then you can take how it is going to be helpful. Yes, yes. Yes. So there are now regulations are being implemented in most of the data sets, particularly what we have in the ICMR and DHR. But we are trying to take it forward to the public health sector and the tertiary health sector, where these can be helpful. Okay. And this One Health is another one where you can see where it is useful, and digital twins and clinical research. And these are all the electronic health records and clinical data where a lot of AI can help an important role. This is one. And there you can see missing data, labeling noise, heterogeneity, privacy sharing. All these things need a better thing. And also this low median income countries has the biggest problem in challenging all those things. And one particular disease where it is completely used is TB, because we are right now we are employing AI in all the models. So starting from community screening to diagnosis, lab genomics, treatment optimization, outcome surveillance, and research policy. So everything is now being dictated by AI now. So it is not a medical doctor or a community practitioner or a medical researcher. There is a role of AI in delineating the each and every aspect of the disease. And these are all the key resource data where you can see a lot of databases are there for TB, and these can be helpful in the research journals. So this cryptic database, and then Harvard Zitnik link, and some now IIT Madras and AIMS is giving a generating data for a lot of chest X-rays, image X-rays. Now ICMR is funding for all IITs to do this image-based diseases, and particularly for TB. So these are all the newer places where we can have the database. And these are all the finally career pathways. So maybe students, I think this can be, something interesting. So these data, like as a clinical AI engineer, and then bioinformatics scientist, then global health AI researcher, regulatory aspects for AI specialist, and epidemiology data scientist. So these are all the position now we are recruiting an engineering graduate who can come up with newer models to address the chemical medical issues. So after being graduating from this AI, you have a potential in these areas where you can be a candidate for future. Yeah, to summarize, like all these 10 points are the major ones what I felt, which is very rudimentary, and maybe your department have much more knowledge on these applications, but these are all restricted for medical technologies, and I wish this will be much more helpful. With this I just conclude. Thank you very much. Yeah, I'd be happy to have any questions. So I think everybody is aware of these things. So if you have any questions, we'll be happy. Otherwise, no issues. You can always Google it and find it, what it is. Every knowledge is there in the database. So again, I thank the opportunity of the organizers for giving me this to listen. Thank you very much. Thank you.
Thank you, sir, for your enlightening and thought-provoking address.
It is now time to express our sincere gratitude. To propose the vote of thanks, I invite Dr. G. Senthilvelen, Assistant Professor, Department of Computer Science and Engineering.
Good morning, everyone. On behalf of the Center of Excellence in Computational Intelligence and Medical Technology under the Department of Computer Science Engineering, it is proud to privilege to propose the vote of thanks for the academic research conclave TechMed'26. First and foremost, we express our heartfelt gratitude to our respected Chancellor and President of Dr. M.G.R. Educational and Research Institute for their constant encouragement and visionary leadership and their unwavering support for promoting the interdisciplinary research and innovations. We are deeply grateful for our respected Vice Chancellor, Dr. S. Geeta Lakshmi, for inspiring us with academic excellence and for trusting that strong research ecosystem with the institution. And our sincere thanks to Additional Registrar Dr. Cyril Raj sir for their administrative support, coordination, and encouragement in marking event successful. We extended our thanks to Dr. Mehta, advisor, for his valuable guidance and motivation for organizing this conclave. And also, we are thanked to our chief guest, Dr. Ramalingam Bethlehem, scientist HEF, ICMR, Chennai, and Dr. Nirmala Devi ma'am, professor, biomedical engineering, MIT campus, Anna University, Chennai. We would like to extend the special thanks to respected HO, Head of the Department of Computer Science and Engineering, and all the conveners, faculty members, students for their dedicated efforts, planning, teamwork throughout the event. We express our heartfelt appreciation to all the department heads, doctor, professors, and faculty members from the Faculty of Medical Science for their valuable participations and insightful contribution to the strengthen the bridge between the technology and healthcare. We sincere thanks to our chief guests and speakers also, and a special note appreciation goes to the organization committee, technical team, volunteer, media team and supporting staff who behind the scenes effort ensured the smooth conduct of the program. Finally, we thank each and everyone participant and attendance being the part of the TechMed'26 are contributing to the success of the academic gathering. Thank you once again.
Thank you, sir, for your remarkable words. A plenary session offers a valuable insights that deepen our understanding of the theme and emerging advancements in the field. It is now my privilege to invite Dr. S. Nirmala Devi ma'am to deliver the plenary talk.
Hello. You can start. Yeah. Oh. So I think you can start the session with great happiness and pleasure. I would like to thank the Vice Chancellor of this university, thank Dr. Cyril Raj sir and all other faculties and the chief guest present here and the faculty, students, friends for giving me this opportunity to take a session in AI in healthcare. So since the time limitation is just 1 hour, I have to hurry up now, I think so. So these are all the areas where I have focused my research. So the areas like first research taken up in coronary artery X-ray angiogram image with 3D modeling using AI. And we have done glioma detection in MRI by detecting the normal and abnormal detection in MRI images. Then finding out the liver lesion and vessel detection in abnormal liver with 3D surface rendering and volume rendering. Then comes image fusion, wherein I'm fusing two images and finding out the image retrieval and embedding. Then pre and post operative cases by taking the fused images of PET and CT and finding out the enlargement after medication, what has happened. This is a clinical study using AI. Then we design our own biosignal amplifiers. We detect the amplifier and we also implement an FPGA board to find out the abnormalities in signals, biosignals like EEG, EMG and ECG. And of course EOG, ERG also. Then last one is human spine vertebrae using AI techniques. So all these things have been developed as a research work in our, under my supervision, and myself have played a crucial role in this development. So here I'm going to talk in depth in technical. So please bear with me. I got a lot of slides, so I'll make it fast. So I think I can, which one you students wanted very fast? Which application you wanted? Students from your side. Which application you wanted, human spine or signal acquisition or fusion or coronary, which one you wanted? I can take up fast. Can I go to human spine? Yes. So I got other slides, but I think it's time to show the other slides. I'll directly go to the technical part in my presentation. I'll go to human spine form. Okay, so what is this human spine? Because now we have been sitting for a long time and everything is AI now. Everything you are doing in mobile, everything is AI. At home, you do your app, you do your mobile phone. So we have got back problem. Even at small age, elder age, older age, everyone are getting nowadays. So what is that back problem? Why do you get this back pain? And what is happening at the back in the lumbar spine? So you can see now. So what is the cause of this lumbar spine? You can see there is nerve compression cause, which is having pain in lower back. you got numbness, you got muscle weakness. This is the statistics here, and there are lumbar 1, 2, 3, 4, 5, 7, L1, L2, I'll show the regions now. This is a lumbar disc herniation. So herniation is an abnormal region wherein your liquid oozes out. Since because we have been sitting in a same position for a long time, we are not sitting straight. We are bending ourselves. This is because of that we get this problem, and otherwise also by looking at a mobile and doing a laptop, we get this problem. So even at young stage, you are getting this. Now, what are the types of herniation? Protrusion, disc bulges outward without rupture, extrusion, and sequestration. These are all the abnormal issues wherein we get. Now, how this AI is going to develop this and find out what is herniation in this? How we are going to find the herniation part? Now, what is the main motivation is to find out the herniation in the spine, lumbar region. So these are all their basic things. I don't want to go through this. It will take a long time. Now, what is the objective is you have to pre-process the MRI images. Now, the problem here is both biomedical engineers and the doctors should collaborate to make efficient diagnosis. So you can see in any hospital, the help for the doctors will be a biomedical engineer. So biomedical engineering is mostly needed in all the hospitals, only then, because a biomedical engineer is going to design the equipment based on the biosignals. And also they'll be learning a lot of subjects in DT, diagnostic and therapeutic equipment, medical imaging. So you know what is the therapeutic, what is diagnostic with all images. So an engineer is needed to collaborate with the doctors. So that's why we see in all the curriculum, students go to hospital training where biomedical engineers are needed in a hospital to assist the doctors. So they should be collaborated. So, but of course we don't have a hospital, so I cannot get MRI images. And here we have got a very good hospital. MRI slices can be given to the students and they can do very well AI in this, any imaging modality. So now, so for getting and doing this work, we have to go for ethical clearance. Without ethical clearance, we cannot take up any research work in our department. So the MRI images of human vertebral spine can be taken, and you develop an automated approach for accurate intervertebral disc localization, classification, and herniation analysis in spine. So you can see the herniation in the lumbar region. So therefore, thereby the doctors can go in for surgical planning. So how this AI is developing this is the objective, and there's the overall block diagram. You can see in the block diagram, you can have pre-processing. You take the number of slices, you do pre-processing. Then in this pre-processing, what you do, you have to enhance the contrast. That because it's all an image from a hospital wherein the images are not of high contrast. So you do some contrast enhancing, you remove the noise factor, and then you go in for segmentation. Then you find the textures, spine abnormality, you find normal or abnormal, and then comes your AI in this. Where is AI here? Your IVD localization using YOLO V2 IVD. YOLO V2 is an AI technique here. And this YOLO V2 is again given to eAlexNet, enhanced AlexNet, which is an AI. And then you find the identification. And at last, when you go to any doctor, if you go to an ortho doctor, what they do, they'll make sitters, they'll show the model of your ortho, and they'll explain what is happening to the upper arm or lower limb, what is happening. So they have a model, and then that is why they explain. In all the hospitals, doctors, they bring a phantom or image, they take a model and they explain what is it. So that is what, it's very important. You have to generate a phantom image or a model from this AI technique. So this is a flow now. Now here, you are doing AI only in this block. But why not pre-processing and segmentation? AI can be taken up in also pre-processing and segmentation. But normally what we do, AI classification. We normally say classification, classification. Need not be classification. You can do AI in pre-processing, AI in human vertebral segmentation using a Python software. You can, using a Python software, you have got Python software, and there's other lot of Keras. You do all this and put AI in that, you can do pre-processing in that. And then you take it to your spine. Now see how it is generated. And always AI classification, what we do? We know the parameters in AI. AI is nothing but a human brain, how it works. So now we are all normal. We are able to learn. We are able to adapt. We are able to recall. We are able to record everything. And then we are able to reproduce. That is a human brain. The same contest a machine has to do. So we are allotting all these human brain characteristics in the form of a circuit. That is what artificial intelligence. So what all is needed in this? So we are able to eat. When you are born, do you know all these things? No. We have been learning from our parents, learning from our ancestors to do everything, to rise, to walk, to write, to learn, to sleep, everything. So that is, your brain gets developed, your neurons get developed in this. So this is being substituted in the form of a circuit that is called artificial intelligence. Clear? A machine does this now. Our human brain is being given to the machine now. So AI does this. Understand, students? This is what AI. Now, what is it in this AI? You have got convolution neural network. The base of AI is convolution neural network. What is convolution? You have got lot of filters in that. So how many filters? Many number of filters. Then you have got RELU layer. That is rectified linear unit layer with find out see feature extraction. Then followed by a softmax layer, wherein you have got a sigmoidal function to activate your function with binary zeros or ones. And that this is how your AI concept comes in the convolution layer, RELU layer, softmax layer, then comes fully connected layer. It takes all the inputs and does it. And in between you have got a max pooling, average pooling, then comes your stride. So all these things for your convolution. Clear? This is a basic thing for your AI concept. Now among these basics, I can bring it down. What you should know is how many layers each convolution has downsampled. Because we all say AA has this, but what is it array size of a layer? We do not know. We cannot explain this. So the importance of AA is when an image is given, suppose 256 cross 256 is given as input. So for a RGB image, your AA will take 256 cross 256 into 3. Understand? If for a grayscale, it will be computer science students. For a grayscale, what could be the size of your image? 224 cross 224 into 1 or 2? 2 for a grayscale. So you should know the basic image size as an input. So because you have to give the input slices. So when an AI works, you have to get number of slices. So what should be the size of the image? Height, width, and your color, whether it's RGB or gray. 224 cross 224 is your height. Height, width, and your color, whether it's grayscale or RGB. That is the input size. Now, this input is going to first convolution layer. Then, second convolution, when it takes the input, what is the array size? How much it has reduced? So, 224 has reduced to 218 cross 218. Then, third convolution layer, it will go to 200 cross 200. So, you should know the array size and then it converges. It has come to 64 cross 64. Then, you will get the converged output, which is coming down. You should know the array size when you do design your AI. Because AI students do. They don't comment on the array size. So you should know the concept of AI. Now we'll see what is this. So now this is a pre-processing. So what are all the steps? Contrast, denoise, then take texture features and then find your abnormal. So you're using some pre-processing concept. And all these things can be done in AI concept. All can be done in AI. Now how many patients I have taken? Only 72 patients. So for an AI, how many patients we need? More than 2,000 patient slices. But I don't get any patients because doctors have not given me input. So what I do? I can do in another form to augment your image. You do augmentation. What is augmentation? Take an image, do scaling, do rotation, you do various forms of scaling, stretching, rotation. You can shrink the image various degrees. You do augmentation and that can be taken as an image to the input by increasing your image size. Now there are 13 slices. Now all these slices are all lumbar region, L1, L2, L3, L4. This is in the lower back lumbar region. Now see here, we have done this pre-processing. I have applied some Clackey method and histogram method. I think this technique I need not explain. It's no time for me. Then what is a view? When I give this image, I need to give all the views. Sagittal view, coronal view, and axial view. Because AI can take all the views, you can increase your image data set. But in which view your abnormal portion is noted, that is most important. So that with the help of doctors only we can take. So you should need the ground truth from the doctors. Okay, so now in this, I felt sagittal view, I can find the herniation part very clearly. So in my study, so since I've done this, after you do, you have to do all performance measure. You have to study whether the parametrics is, as sir was saying, there are a lot of metrics to be done in AI. What are all the metrics? One metric is your contrast difference. Then a lot of images. Then comes filtering. What type of filtering we do? Median filter, Wiener filter, bilateral filter. You apply this and find which filter is good for all these views. You do some matrices. You calculate your PSNR, signal to noise ratio, mean square error, calculate, and you find which is best in all. Do the analysis pattern, and then for all the views you have to take down, and then comes segmentation. So this is pre-processing, contrast, denoising is over now. Now which is best of all, that is given for segmentation. What is segmentation? In an image, you wanted to segment which part you wanted. So if the image is 256 cross 256, I can find in this lumbar, a portion of the image is infected. So that is segment. You segment that alone and then do analysis on that. So I'm doing segmentation. So under this, I'm doing an algorithm called particle swarm optimization. So here optimization comes inside. Optimization is to bring the highest to lowest. You optimize by doing genetic algorithm. You optimize by using neural networks, because here optimization comes with gradient descent algorithm. The basic thing for this is gradient. What is gradient is always negative. So it is decreasing form. It is decreasing form. A person top of the hill, I'm standing in the top of the hill. I wanted to come down. I have to come down through steps in a decreasing form and come down to the bottom ground floor. So a gradient with highest is coming down gradually, coming down and then coming to the lowermost. That is a convergence in your AI. So a root mean square has to converge. It has to come down. It's a gradient form. Then this technique, the similar way you do this technique, and we have got the flow chart, and then you got some output, and sagittal is giving best result. I'm taking particle swarm and finding out this. Under this you find lot of morphological operators. You do find the edges in your operator. You wanted the edges of your lumbar spine perfectly to find any herniation in the edge. So I'm doing some edge operator called morphological operator. Then again, do some matrices for that. So find all this measures. Clear? Then comes machine learning algorithm. Machine learning algorithm is a supervised algorithm. It is not unsupervised, because we take the features from the result and we give for training and testing. It's a supervised algorithm. So under this machine learning, I'm using a concept called gradient boost model. So these are all the results. I'm finding out the textures using this. What are all the textures? Correlation, energy, homogeneity, skewness, entropy, kurtosis. I'm finding the features in venue. So what are all this? This is as training to a machine learning algorithm. I'm giving a training by taking the features from the best model. Clear? So from the segmented output, I take features using machine learning supervised algorithm, and I'll be testing it later. Clear, students? Okay. Then do all this analysis: accuracy, precision, recall. So what is this accuracy, precision, recall? The importance here is you should know what is the ground truth. True positive. This matrix is very important in AI. Wherever you see in confusion matrix, predicted class, How do you classify with normal? Predicted, abnormal. So where do you go for this confusion? You should know what is accuracy in that. Accuracy is true positive. True positive from where you will get? From the doctors. That is a ground truth. So doctor will give the true positive. I should see whether my machine learning has detected this true positive or not. So this matrix is very important in all our image processing and AI techniques. Then you see, and when you do AI, normally people will do only for 80% training, then 20% testing. That should not be. You should do for all three types: 80, 30, 60, 40, 70, 30. You do for all this ratio. 60, 40 is 60 training, 40, because you have to confuse the AI. So how will you confuse? Do all forms of ratios for testing and training and see which is best of all. That is how you should compare your results. So you can see actual abnormal, actual normal, find the ratios, and at last 80-20 has given best result accuracy, which is 90% and 86%. Similarly, for coronal view also. So sagittal view is good when compared to coronal view. So we claim coronal view of lumbar is fine. Then comes, next is you localize. So after you do this pre-processing, segmentation, now comes your AI technique, and that also can be done in AI, but always to start up with, we'll say only classification. So till now we have not done any classification. Now we'll see the input is given to YOLO V2 model. What is YOLO? You only look once. YOLO means you only look once, intervertebral disc. So this was little famous, I think 2 or 3 years before. You only look model. So now what is the block diagram here? So what is, how this YOLO V2 can, now you can see enhanced VGG, it's an AI network. The input is given to RELU layer, rectified linear unit. So this rectified linear unit will talk about only linearity, but we wanted non-linear because the image is not linear. So we wanted to convert this RELU to non-linear, and then you go to YOLO V2 model, then you localize, then again you come to AI technique, ELXnet, then you calculate your herniation severity in using morphological operators. So this is the concept in AI technique, clear? So now you wanted to find localization and detection. So you use YOLO V2 model. Now see that AI now, what is it AI has? You have an input image, this here 180 cross 180 into 3, because 3 is RGB. 3 stands for RGB. Now here I'm giving the VGG network, and you have got YOLO V2, YOLO V2. So how many convolution layers are inside? I just drawn only one convolution layer and one batch normalization layer BN, and then one RELU layer, then transform output. But inside there are many convolution layers, many RELU layers, and many batch normalization layers. This is how an AI, CNN, whatever combination, all takes place in this form only. And then you get your localization score. So here, RELU, convolution, batch normalization, and then transform. Inside you will have filters, strides, then softmax algorithm, activation algorithm, all this will be taking place inside. Learning will take place inside. But people doesn't know what is happening inside. So that is why I'm saying, when you give an input image, each stage, what is the array of your array size should be noted. Only then we know whether it is converged or not, A has correctly classified or not. So now you can see, there's a tabulation, and here this is the architecture, other architecture. You can see the layers here. 180 cross 180, 64, 90 cross 90 cross 188, 45, 45 cross 256. It has gone down, then it has gone to 1 cross 1 cross 1. It has become one-dimensional. This is your AI concept. How your array size has been reduced to each layer, and then it comes to one-dimension layer. Now you can see the comparison here. So first, what has happened? Convolution A, convolution B, then max pooling, all these have been given here. You can see the kernels, what we have used. Kernel is a filter size. When your kernel size, then see the activation function, how it has gone down. Each type, each layer, you are given the array size, and the last shows dropout algorithm. This dropout will is important, wherein it minimizes the loss. So dropout should be very minimum. There should be only few dropouts, which means your AI has converged and there is no loss. There is no, it has not taken, lost any pixel or any signal in that. It has done very clear convergence. It is 1 cross 1 now, 1024 into 1 cross 1. So what all you have? Convolution layer, max pool, then you got flattened layer and dropout layers. And what is the dropout layer? The difference between a normal VGG and enhanced VGG. We are comparing both. Always in AI, you should compare two things. A normal, an existing, a conventional method, and what is a proposed method. So I'm doing some proposed method and can see VGG has got reduced to 180, and all your dropout has come down, and the total parameter is 25 million. The input was 138 million data. In your VGG, in enhanced, it has come down to 25 million only. It has reduced since because I trained with minimum epochs and I got it to minimum time and minimum loss. This is how the comparison has to be taken out. So it's all for the students I'm explaining. So you should know how to take up your AI concept. So now next is YOLO V2 IVD model. So what are all the losses we have got in this? Localization loss, confidence loss, and classification loss. So this losses, again, you should calculate, and you can see what are all the lumbar regions: L1, L2, L2, L3, L4, L5, L3, 4, 4, 5, and 5 to a spine, lowermost spine. So now you have to find all the regions where there is herniation, where there is a leak in the lumbar vertebrae, and how this can be treated. Because when there is a liquid leak, again, we should not put stress on that. We should not sit and we should not have the same condition of previous. So now how to avoid this? So what can be done? How this can be even operated for surgical planning? So now you should take the measurements of all, and this is the result of your AI network. You can see everything has converged down. It has all converged down. All the models have been trained and it has converged to lowermost. This is your root mean square. So root mean square, the error has to come down with how many epochs? Then loss. See, the loss is also reduced with 15 epochs. And then training loss and your root mean square loss, you have got mini batch root mean square error. So you can see the difference between your YOLO model and your YOLO IVD. You can compare these two. The comparison is shown, and then the results of your spine. So you do the comparison and you find out, you can see the readings given in all 0.706, 0.809, 0.83. You're finding the vertical, because when there is herniation, you have to find both vertical and horizontal. Both axis has to be noted. So I'm finding the vertical axis as well as the horizontal axis for herniation. So here, this is horizontal, the values of horizontal, and then you can see your vertical also. The next one is your vertical testing, vertical localization. So now you have to test. Training is over. Now you test by giving another image. You test your model. You do testing of this. And then you find out the evaluation procedure. You find out the scores. You do the evaluation. And then you use Alexa, because the block diagram you have seen. You did two networks because this is a hybrid classifier. It is not one AI technique. I'm using two AI techniques. One was YOLO V2, the other is EAlexNet. I'm taking two networks and using a hybrid way of determining the herniation. So this is again an hybrid enhanced AlexNet. You all know what is AlexNet. This is an enhanced AlexNet. See the convolution, how many convolution? 1, 2, 3, 4, 5 convolution layers, fully connected layer, and what could be a results we'll see now. So stride I said, it can be a horizontal stride, it can be a diagonal stride. If the stride is very nearer, you get very fine results. If it is very further away, then you will be getting overfitting in your results. So overfitting should not occur. So your stride selection is most important. You see the AlexNet layers, kernel size, stride, and then activation function. Then how do you classify this? The parameters, what has been taken for AlexNet, dropout, neurons, total parameter, the time it takes is eAlexNet has given a best result when compared to a normal pre-trained network. So you're enhancing your AI technique here. And then how many epochs it has taken, this model, and what optimizer you're using, adaptive optimizer, which is ADAM. Then the results of this training, how it converges with loss. Then comes testing result, and then results. Okay, now you have come to know what are all this. After you do all these things for students and research purpose, you have to compare with the existing person what they have done. See the existing person what they have done in 2017. They have identified this spinal stenosis. But what we have done, proposed net disc herniation, I have done in sagittal view, and I use this 2 hybrid network, and I have increased my accuracy. So you compare with the existing persons, those who have developed this AI technique, and you prove yours is better by using hybrid classifier. Okay. And then, okay, now we have come to all this. Now what is the use of this work? That is the question now. So I like this. We have taken up all. Now what is this going to make you, how this can be used for the doctors, how this can be helped? That is the main question. Now we have done this, but what is it you can do here is, this has to be modeled. You are done, you have found out the herniation, and I wanted to say whether this herniation, I should not have any stress further. I should find out the mechanical parameters. Mechanical parameters, so mechanical is also involved in this. So what you do, you try to model this lumbar disc, and you find in this model how much stress can be given, what should be the strength of stress, what is the material I can use for surgery for doing this. So that is what you should be an end result. So you can see here, I have done a modeling in this. And then for this model, I have to go in for a big 3D model. So mainly students do mechanical, they do Cativia software. I think Cativia software all are doing. So we have a software called Mimic software. So we have got that software when you do in model in that. So we do model, and then this model will be in a format of CSV, I don't remember. This model should be given to the 3D printing. So you get a 3D printing of that, and then do stress analysis for this. That is the important configuration. You do stress analysis using FEA, finite element analysis. So mechanical is also involved in this. FEA should be done. So I'm doing an FEA concept. So what are all the, when you do FEA, mesh is important. So this is fine. I wanted to find a fine element, fine material. So I need to find out mesh analysis. The surface should be smooth. There should not be any hollow inside. If there is any hollow in that mesh, then it is some leaking inside. So there is some pixels which has been not used for analysis. So it should be a uniform surface. So you should go for mesh analysis. It's called FEA. So use FEA. You do geometric mesh, deformation stress, strain, intervertebral disc height, and then go for 3D printing. Clear? So now you do all this analysis, and then this is an example for a 3D modeling. So we have done 3D modeling, use our own software, Mimics and Cativia, we combine both. Then for these slices, so for again doing this 3D modeling, we request the doctors to give more number of slices. Without that, we cannot go in for 3D modeling. Then at last, so we are done like this for 2 images, and what is it you have concluded? We have done density, Young's modulus, Poisson ratio, bulk, shear modulus, we are doing the properties of tissue because this has to be implanted. So we have to do all this analysis. Then you find the values for all using your 3D and FEA analysis software. And then you find out the mesh size. Then you can also use ANSYS software. ANSYS, Cativia, Mimics, any software you feel. And then you can see the mesh size, number of elements and the time taken it. And at last, what is the load can be applied with frictional force of 0.02. How much load I can apply for that material so that I can withstand that when it is implanted. Then deformation in bone and tissue, stress in bone and tissue. Then at last FEA analysis for various images. Then the maximum stress point, stress analysis to be taken up, and the measurement in disk, then standard values, and you had to compare with the existing standard values with reference to the doctors. So you can see the standard values for L1, L2, L3, it is 6.9 plus or minus 1.3 for men and women. It will vary for men and women. The lumbar strength and stress will vary for men and women. You take the standard values and compare, and then you try to check with your answers. So then we have compared it and found we get the same with plus or minus minimum error, and then we concluded and we have done a 3D printing on this. So now this makes the doctors to analyze and find out whether it can be used for diagnosis purpose. Because all these things we do and we give the results to the doctors. They can use the software. And this software they can analyze for any patient and they can conclude whether the herniation is of what width, size, stress, everything. That will be helpful for the doctors. This is one which is really needed for doctors. And many MMC they came here and they said, we wanted this algorithm, we wanted to take up this, and we wanted that model also. So students, you can also try on this. Okay, so hope you would have understood now. Okay, can we go to the next one? The next one is, as sir was asking, FPGA. We started using FPGA. So here we are used, what we have done is, this is based on my funded project, but you should all know that AI now, it is doing with embedded system. So how AI is implemented in the embedded system? What is embedded system? You are using some hardware inside. You are using some microcontrollers. So AI works on microcontroller. Everyone should know it works only on microcontrollers. So microcontroller is a small device wherein it takes very minimum time to execute your process. So you're using a microcontroller using FPGA. So electrical comes inside. So electrical students, not electrical, everyone should know a microcontroller, how it works, and embedded processing. Using that embedded, we took this project, real-time FPGA-based prosthetic hand controller using EMG signal and haptic feedback. So what we do, haptic feedback is your feedback with a sensor to touch and feel. That is haptic. When you touch something, you should feel. I'm touching you, you have to feel for it. That is haptic. Because when a person doesn't have his upper arm, now you have to go in for a prosthetic device. So you give that prosthetic device, and then we should give him artificially by giving some signal so that he can feel that. So you have to design that. So using a microcontroller. So we have started this with a 16-bit microcontroller. It's a very Zybo kit. 16-bit controller. We have started this, and the objective is here we design our own biosignals. So we don't get any kit from outside. So our own biomedical students, we design an amplifier, but most college, I don't know, but biomedical students, do you design your biosignals? No biomedical here. UG biomedical? Okay. So normally we should teach them to design biosignals. So we design our own amplifier for a gain and frequency. We design amplifiers, And from the designed one, we give a real EMG signal by keeping the electrodes and how it works in our FPGA. So what do we do? So FPGA has got hardware processing and software processing. So software processing is by using filters, FAR filter, IAR filter, high pass, low pass, all these filters. Hardware processing is to acquire, after processing, how to give a sensor to acquire touch or feel for the amputee patients. So what we do, we acquire and condition the surface EMG signal. We digitize the signal because a microcontroller is a digital output. So we digitize the signal through ADC and interface with the FPGA board. Implement FIR filter. Why FIR filter is chosen? Because it has got a feedback. So FIR filter and feature extraction using VHDL. Then I'm using an AI network here. What AI is used? Spiking neural network. I'm using an AI technique. I'm implementing this in FPGA board. For gesture recognition, gesture is open, close, flexion, extension, because they don't have upper limb or below elbow. So I'm making them artificially, designing a prosthetic arm and asking them to open, close, flexion, extension, then ulnar deviation, the movement of all their artificial hand. Then generate a pulse width modulation to identify whether he is able to say, yes, I can open 0 or 1. Pulse width modulation with a 50% duty cycle. To control the servo motor, then provide haptic feedback by analyzing force angle. So here haptic feedback using a sensor. So what sensor I'm using? A pressure sensor. I'm keeping the pressure sensor on each finger. I'm finding out the angle. So how much is able to close, how much is able to open, because I need all this gesture to enhance the user experience. So now, so what all we are taken? We can acquire the signal using our own amplifier. In case we don't have, we can also use your own hardware by acquiring the signal. Now see the block diagram, how it goes. EMG signal, then export your MAT file to PC, you use an ADC, convert to .me file, interface, then FPGA board, digital filtering, feature extraction, and here comes the AI technique, SNN network. So we are comparing CNN and SNN because that is a pre-trained network. So compare CNN and compare your spiking neural. Spiking neural network is whenever you get spikes, that spike will be taken as your source. That will be executed. Then gesture mapping, PWM, then prosthetic control view. Okay, so now this is a data acquisition form. I think this you can skip out. Now see the readings, how you do. We are finding here FIR filter. You take passband filter or testing. You should do all this readings. All these things is done in Python as the input side. For in FPGA, normally you should need an high-end GPU. Otherwise, you cannot run FPGA board. So you should have a high-end GPU to do FPGA testing. So only certain departments, I don't know, but we didn't have GPU. So what we did, all their AI testing was done in outside Python. For testing alone, we gained for board level. So training was done in Python, testing level was given in board level because we didn't have GPU. So this GPU is needed so that your FPGA really works. When you take MATLAB, it takes long hours, it will be hanged. You cannot run, even in 5 days it won't run. But FPGA within just 20 minutes, 20 seconds you can get your output with a high-end GPU. So now this is the FPGA board we have used, Zybo 7 board. It has got all these modules inside. And this is a Vivado hardware using Xilinx. So here you can see the hardware processing. And this hardware processing has to be linked with Vertis board. You have to interface this Vertis, and then you should execute your hardware and software. So that's again one interfacing unit with Vertis. So you can choose a compartment, whatever you want, which filter you wanted, you can replace that filter, you can do your hardware processing. And here you're loaded, and you can see it is used to extract your features also. You can extract your features. Then this is your witness software. For software, this interface is needed. It is in the Zybo board using via UART, and then it stores, and you can get your output. And you can see your received EMG data bins, FIR filter, and feature blocks are displayed in your system when you use this interface board. And digital filtering using FIR filter for the order n equal to 1 to 7. Test the order and see why this order is chosen. So each and everything you have to show the results, whether it is, and you can see this is a EMG signal. Filtered EMG signal, filtered EMG bandpass FIR. Then here, it's a frequency spectrum, original versus filtered EMG at 45-degree angle. So each stage, you can see the display in your Vertis board. And the features are taken in this. And now we are comparing the models like machine learning model here. So the machine learning is also your AI. It's also AI, but this is a supervised learning. So what is it? Linear regression model, K nearest neighborhood, support vector machine, and spiking neural network. Spiking neural network is an unsupervised algorithm. So we are comparing supervised model with unsupervised model. So here unsupervised, only one network I have taken, but we are also doing with CNN. CNN didn't give maximum accuracy. So this is all a supervised with unsupervised, and you can see the plot, how it has been trained, and there's a confusion matrix everywhere, and everywhere in your ANN, you can see the confusion matrix arises. The confusion is only for testing and training. So you get your accuracy output, and when you take your confusion matrix, you should know one concept. The entire array size of your confusion matrix should be the samples what you given. That is how you can verify your results. So you verify your results of that form, and you can see open, close, flexion, extension has been identified. Your accuracy, your weighted average has been displayed. Then comes SNN classifier. You do SNN classifier using testing using your Python, and then training in Python and testing in board level. So your SNN classification result, your confusion matrix is given. You can see the open, close, precision, recall. These are all the metrics you should do. These are all the very important metrics in all your AI concept. So this is the metrics. You compare with your confusion matrix. And here your confusion matrix will say actual and a predefined. You can find your gesture in all. So likewise, you should do for 80-20, 70-30, and 60-40. And at last, we do the training process. And this is what your hardware level. You do FPGA, and you can see the results by connecting your hardware. You use your hardware in finding out this. And here, we are using one library function called TensorFlow, wherein TensorFlow has got all the libraries of your feature extraction concept. Use TensorFlow to acquire all your libraries, and you get your results here. And then you can justify your results in your FPGA board. Then you should compare why you do in FPGA board. Your latency is very important. The time it takes is very important. So we have to prove the latency. So latency is just 16.7 microseconds. This is the importance. Whereas if you do in MATLAB in other thing, it will take more than hours. It's only 16.7 microseconds I'm able to determine the actual exact gesture application in your FPGA board. So FPGA board is inside your all system, which is a microcontroller. So latency is important, and then you compare your charts. So with this, you can see how your model is being activated. So we have tested the haptic by placing the pressure sensor on each finger. You're finding out the open close angle with a pulse indication of 1 millisecond, 2 millisecond, and you're finding the results. And all these things have been designed by us. This hand is an original person CT image, and a person who has got right hand, he didn't have left hand. So we have taken this as the reference, and we have designed this entire thing, and that is an original hand of the amputee person. So with that only we can find out the 3D model and design, and we have done it. The results are fair enough, and this is how This can be taken up in here. And we have got various servo motors. This is all here lab. We do all these boards and things, and we design our hands. And these are all with the collaboration with the MMC. So we got collaborated with Rehabilitation Center, and they help us to give the image, and the doctors help us to, because electrode fixing also, the doctor help us which muscle we have to keep the electrodes. So they are giving us the direction. And this is a pressure sensor. We are facing it in the center finger, and all this we are done. This is an application of AA in FPGA board. Clear? So this is all the scope which is mostly needed in FPGA. This is a minimum board we are taken, but there are more resolution boards. Testing and training can be done in more resolution boards like ultra boards. But this is minimum we are done in 16-bit resolution in a minimum board, where testing is done in board, training is done in Python. Students, do you all understand? I don't know. Okay, so next, what we can do next is, can we go to the angiogram? So you wanted to find the heart block. You should know how to determine the heart block using AI technique. என்ன பண்ணலாம் சார்? எல்லாம் ஒண்ணுமே சொல்லல, இன்னும் நிறைய இருக்கு. இன்னும் நிறைய இருக்குதா? நிறைய இருக்கு. At least outputs I can show them, no? Can I show the outputs for all? Yes, that's the output alone. Just 10 minutes. 10 minutes I can show the output. No, because you can get some idea of your projects. Just 10 minutes. Okay. So now here, AI-based segmentation classification of hemodynamics, CFD, as I was saying, you should know how to design an CAD for heart block, and how to use 3D modeling. So you can just show the results. Now where is AI in this? You have got AI all everywhere here, deep models, machine learning models, segmentation, and you are finding out whether your heart block is ischemic or non-ischemic. Clear? So make it fast. Now again here, you need slices of your X-ray angiogram images. So you need slices. Only with slices I can go in for 3D modeling and AI technique. So you can see the various slices wherein the blade, the contrast agent has been arriving from the top to the bottom in all the slices, and they can determine where is the block and shrinkage in your blood vessel. And in this blood vessel, you have got minimum major blood vessels, small blood vessels, and everywhere there can be a block in this. So now try to do all the pre-processing techniques, and then you can see the confusion matrix for machine learning. You use these algorithms. Just have a glance. I'm making it fast. And then you're using an AI technique called graph attention network. It's an AI technique. Then your attention map, see the accuracy and compare to results of CFD. Then again, there's another one, AI technique, enhanced graph attention network. And you do CFD analysis. So what is this hemodynamic analysis? Is using a biomechanical. So biomechanical, you find the pressure, velocity, stress. So you can see the feature is what is taken here. So you can see here what is pressure, velocity, fractional flow reserve, and CFD derived wall shear. These are all hemodynamics parameter for measuring your block in your blood vessel. So with this, you train and test your network. With this features only should train, not taking kurtosis, standard deviation, mean. You should take these features for your identification of block, hemodynamic features, and then you have to, because we need to find the pressure and velocity where the block is. And what is because the contrast agent is entering inside, you have to find the blood flow. So find the blood flow, velocity, and pressure. So then you do all this analysis. Okay, so with this, you can conclude which AI network is good for detecting your pressure and velocity. Okay, so this is one concept. The last one. Okay, sir, I'll leave with this. Okay, thank you, students, for your keen listening, and hope all are hungry. So now your brain has learnt something, I don't know whether it is adapted, and you can recall something, whatever Chief Guest Sir and myself and other faculties have told, try to recall and then try to reproduce. That is called AI network. Okay, with this, thank you, students.
Thank you, ma'am, for your insightful and inspiring plenary address. Your valuable perspectives and expertise have truly enriched this gathering and provided meaningful direction for the sessions ahead. Thank you once again. I request the people who came from medical to stay back, and the rest of you can leave and their snacks provided.